Dr. Elif Bilgic, and I'm an education scientist in the Department of Pediatrics and Merit. So Merit stands for the McMaster Education Research, Innovation, and Theory Program, and it is an education services program in the Faculty of Health Sciences dedicated to advance health professions education scholarship with a vision to grow a community of scientists and clinicians to advance health professions education through research and applied science. Although today's education rounds is virtual, many of us in this event are connected by the land on which we work. So I want to take this time to recognize that McMaster University is on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the Dish with One Spoon Wampum Belt. The wampum uses the symbolism of a dish to represent the territory, and one spoon to represent that the people are to share the resources of the land and only take what they need. Before leaving the stage to our esteemed guest today, I will provide a very brief introduction. The title of today's education round is Beyond Individual Learning, Systems Learning and Translational Educational Outcomes Using Healthcare Simulation. And we have Dr. James Leung as our speaker. Dr. Leung is a simulation educator, researcher, and leader at McMaster University in Hamilton. He serves as Assistant Dean of the Center for Simulation-Based Learning, or some of us might know it as CSBL, and Assistant Professor in Pediatric Emergency Medicine, practicing at McMaster Children's Hospital. His work focuses on using healthcare simulation to improve emergency care for children, enhancing interprofessional continuing education, and expand simulation access in low-resource areas using distance simulation. With his expertise in mind, the rounds today will focus on reviewing both the evidence and experiences using healthcare simulation for team and systems learning. It will be relevant for all healthcare education scholars in expanding the scope of their work from classroom to bedside. Now, during the rounds, feel free to use the chat for comments and questions, as I will ask those during the Q&A period, but I know that Dr. Leung has incorporated Q&A throughout his presentation, so just feel free to use the chat for interacting. But also feel free to ask questions by using the hand-raising function as well, either during or at the end. So without further ado, Dr. Leung, please go ahead.
Thank you so much for that kind introduction, everyone. Honestly, I'm just so privileged, I think, to have the opportunity to present to you guys. Ultimately, I hold the Merit Group in such high esteem. I think the amount of education expertise and excellence that this group represents is something just so unique. And I think we should all be proud at McMaster for what Merit is and what we have. So honestly, I'm just so privileged to be able to present some of this work to you guys today. So I come to you speaking with about a lot of like focused things in simulation, but one of my hopes is that actually we can generalize beyond sort of just simulation-based education in this sort of sense. So without further ado, we'll just jump into the material overall. I just wanted to expand on Dr. Biljic's land acknowledgement as well. One of the themes, I think, of this talk is that translating some of our knowledge into action overall. So one of the things I'm trying to do in my work in reconciliation is encourage us to read around some of these topics. So one topic I thought that was highly relevant for our group as well is this sort of systematic review of Indigenous cultural safety training interventions and some of the data that goes behind it, which is quite fascinating as well too. I'll post the link here. It's an open access journal. So one of the things I'll ask people to do is to take a quick read of that. I think that's important, especially in my work as a pediatrician. I think about all of the horrible things that have happened with residential schools. And I think that the more we do in this field, the more important it is overall. So please have a read of this when you have an opportunity. Before I continue, I wanted to state I don't think I have any relevant disclosures to this talk overall. I am an employee of McMaster University as well as Hamilton Health Sciences. To be fully transparent, I've done some previous contract work for the Royal Colleges of Physicians and Surgeons of Canada. That mostly relates to my work with the virtual resus room. This is a free and open access platform. So it's a non-profit sort of platform that I've served as one of the lead developers and researchers of this platform. So I don't think is relevant too much, but again, in full disclosure, that's what I'm going to state. My hope to you in today and talking to you is really just focus on sort of three core objectives. I think by the end of this talk, my hope is that we can be able to compare and contrast simulation activities as well as just in general education activities that are conducted with the systems integration and translational outcome lens, and compare that to sort of our traditional education paradigms that go across with things. Secondly, I'm hoping to discuss and consider some of the potential system grade integration translational outcomes that can come in your own education research and get brainstorming, I think, on that aspect as well too. And finally, have a bit of a discussion at the end about sort of the considerations, the challenges, and also the opportunities of incorporating these kinds of outcomes in healthcare education research in general overall. To accomplish these objectives, I've divided the talk in terms of four main sections. One section, the first section will be sort of an explanation about what traditional healthcare simulation is and what that sort of quote traditional focus has been. Second, I'll introduce the concepts of systems integration as well as translational simulation. And third, we'll walk through some case examples and studies. We'll see how time goes with that because I think this is the one section we may gloss over if time is becoming limited. Because I think really the fourth section is really the important part as well, especially with our audience today, which is, how do we move from class to bedside and what translational outcomes may mean to you in your health education research practice. So just to start off with sort of traditional healthcare simulation. Healthcare simulation in general, I would say, is, we're relatively late adopters of this methodology overall. So it wasn't really until 1955 that really the first simulator that was described was made, and this was Risasi Annie that was developed from Laerdal. The technology was relatively stagnant up until 1969 when the first high fidelity mannequin was developed, primarily for anesthetic uses as well too. And another sort of 3 or so years passed, and interestingly enough, I think McMaster University is proud to have Dr. Howard Barrows as one of the founders of standardized patients that sort of pushed the needle forward a little bit overall. And a lot of the field, honest, was growing. It was kind of like a niche field overall up until 1983 when Dr. David Gaba really took things over. What Dr. David Gaba's work sort of resulted in was a big inflection point in terms of healthcare simulation education. And a lot of early adopters, Dr. Gaba was an anesthesiologist, but a lot of early adopters came after his introduction of and reintroduction of healthcare simulation and really sort of popularization of many potential utilities and uses. So multiple adopters were involved in multiple specialties. Importantly, nursing education was a large founder of simulation-based education. They also publish currently our standards of practice as well through their Inaxel network. A number of medical professions also were involved as well too, primarily from the undergrad professions, and a number of postgraduate programs, in particular pediatrics, anesthesiology, OBGYN, the critical care specialties, emergency medicine, surgical fields, as well as some of our pre-hospital colleagues as well too. A lot of this education work focused primarily on three questions. First of all, does simulation work? And in summary, I would say a lot of the studies as summarized in this big systematic analysis, sort of the biggest one that was done and published in JAMA in 2011, show that, when you compare simulation to no simulation, that simulation in general had a number of positive outcomes. This is a relatively small figure on this diagram, but essentially for a number of domains in practice, simulation was demonstrated essentially to be favorable overall. In particular, most of the studies were in regards to knowledge acquisition. There were a number of studies looking at process skills, so procedural competency, sort of changes in behaviors, and then ultimately patient outcome all afterwards. As we move from left to right, the number of studies steadily decreases appropriately as we would expect in terms of where things go. So most of the studies, around 118 were in the knowledge domain. And then gradually as we sort of move across here, we get to as little as like 30 studies that look at patient outcomes. A second part of these early foundational literatures focused on, how does simulation compare to other methods of education out there? In simulation, this is a question that's always been at the forefront of what we do, really because it's such a resource-intensive method of education. If ultimately doing a lecture or some sort of didactic learning results in similar forms of education efficacy, oftentimes because of the resource implications, it might actually be favoring more of that sort of traditional form of education. So there's a couple of systematic reviews to talk about. The first one really compared simulation versus traditional sort of clinical bedside rounds education, that sort of see one, do one, teach one paradigm that's out there. And looked at around 14 articles from a meta-analysis overall, primarily looking at clinical skill acquisition. For a number of these studies, mainly focused on procedural competencies, the evidence would suggest that simulation, with a moderate sort of effect size, would favor this as an education technique over traditional sort of, clinical exposures. Similarly, simulation compared to other educational methods. This is a systematic review that looked at, comparing simulation to lectures, some standardized oral examinations, face-to-face small group discussions, computer-based discussions, video-based teaching, and paper and textbooks. Also favored towards using some of this education as an outcome, overall. They overall were able to notice improvements from satisfaction, knowledge, process skills, and ultimately a similar trend was noted throughout as we move from the satisfaction realm towards some of the more difficult outcome measures. The evidence becomes increasingly a little bit more hazy just overall. The third question that a lot of these early foundational papers looked at was, ultimately, does simulation improve patient outcome? And from that, a systematic review, really as a sub-analysis of that first one that I showed you, was done, and this was the sort of the first and biggest one that was done overall. This identified essentially 50 eligible studies from the beginning and ultimately looked mainly a number of skills that were required and focused primarily on procedural skills overall. These include, again, surgical interventions, airway intubations, survival from CPR overall, and different sort of line insertions as well. And what they found just overall in general is that they concluded that from this systematic review that, there is some question about study quality, but there appeared to be some sort of small to moderate patient benefit when you compare this to no intervention overall. And when you actually look at the actual forest plot data, it is fairly, spotty overall. You can see fairly for a number of papers, there are very large confidence intervals that can be shown overall. And in sort of the pooled analysis, it did sort of favor, simulation just overall. So the evidence at that early point, up until the early 2010s, a lot of it really focused or showed that, that simulation was helpful from an education and a learning perspective, but really some questionable benefits when it came to sort of behavior change and actual, patient care and impact overall. And as someone that was coming into the field, and I can't believe I can say this, that like I'm 10 years into my career at this point and coming into that, when I was coming into this, this is a big question that was driving a lot of my thoughts and actions when it comes to simulation. And a lot of my questions, ultimately boil down to this, if simulation doesn't improve clinical outcome, which I felt that it did, why continue to do so? So this was a question I think that again was a big thought in not just my mind, but a lot of simulationists' minds as we're performing our academic work. What this led me to think a lot of was this idea of sort of systems integration and translational simulation as concepts. And it's important to note that, at this time that was parallel to this sort of exponential growth of healthcare simulation, what also happened was the publication of an important landmark study from the Committee of Quality of Healthcare in the US, known as the AIRS Human Report. And what this led to is essentially an exponential growth when it comes to patient safety as well as quality improvement as a motion. And this spurred the development of so many different patient safety institutes that came about. Notably, one of the biggest ones was in the US, which is the Institute for Healthcare Improvement. And through the publication of this landmark report, what the emphasis in healthcare kind of shifted towards was this concept of high quality of care. Care that was defined as safe, it was effective, it was efficient, patient-centered, timely, and ultimately equitable as well too. And as a result of this, what it sort of shifted the focus of was rather than focusing on sort of individual providers in teams, it resulted in a lot of focus in systems and the systems in which both teams and providers work in. And multiple sort of theoretical models came about in terms of describing systems and how teams and individuals fit within those systems from that. One of the most popular models that did come about was this model known as the SEPS model, or Systems in Engineering in Patient and Safety overall. And there are multiple versions. This is the one that was out when I was first looking into this work, which is known as SEPS 2.0, which really describes people in this intermatrix of tools, the organization itself, task, and the internal environment, mixed together with an external environment, and all the processes that they do together that result in the outcomes, which can be defined as patient-level outcomes, different professional-level outcomes, as well as finally organizational outcomes. So with some of these sort of system-based concepts, from a simulation perspective, was landmark, I would say, to help support some of this work, was the development of in situ simulation. So around the early 2010s, one of the concepts that came about in our field was really taking us out of the simulation lab. So this is a picture of our CSBL. In conducting these simulations in areas of actual clinical practice. So this is what our resuscitation room looks like in the Children's Hospital overall. And by conducting these simulations outside of the standardized sort of controlled environment, which focused a lot on sort of teams, users, and some of the tools that go around of it, it really allowed people to really focus on some of the additional aspects of the environment in which simulation was being conducted on, as well as some of the processes that go around with it. And by focusing on some of these processes and environments, it allowed a lot of QI methodology to integrate into our simulation work. So when it comes to looking at things such as processes, we look at sort of Six Sigma models to reduce errors and variability. There's the sort of classic lean Toyota methodology when it comes to processes and environment to maximize efficiency and minimize waste. And ultimately, a lot of thought in terms of human factors engineering. So how do we actually build systems that support individuals and teams and help them when they're in these sort of stressful circumstances? So for a second here, what I was hoping to do is just show you this video of an in situ simulation that we conducted early on. This is probably one of the most scary, as an emergency provider, this is probably one of the most scariest situations where you have a trauma patient that shows up with a pretty much destroyed airway that you have to intubate, but you're not really certain if you can actually complete that procedure. And the next step beyond that, if you're not able to do that, is actually to do a surgical airway, which is to put a cut into the person's trachea and insert a ETT tube in it directly. And the focus I'm hoping for you guys to do is actually watch this video with the systems in mind. So not really thinking about how the learner is performing, but thinking about, what are the systems that are in place for this procedure to be successful.
Don't turn the ball up. We don't.
Like the landmarks? Okay.
Yeah,
Go right
it's
there.
just flushing into the floor.
You want fentanyl given as well? We can hold off on that for now.
Okay.
And those drugs?
Sparks accommodated.
Do you want repeat doses drawn up? Sure.
And I might get you.
The sucks is in?
Yeah.
Yeah.
We'll just wait.
Yeah, I'll take that. Okay, go ahead. Let me know if you want pressure.
Action, please. Action, please.
Visualization is terrible.
Okay, I don't see anything.
Okay,
Any kind of bag? We need to go ahead, Mike.
Yeah, are we can we bag up? As best we can. Okay, I'm gonna start. I'm going ahead with the midline cut. Go ahead. Yeah. Okay, I got good exposure there. That's great. I'm gonna dive right in. Turning sideways. Okay, I'm gonna just dots. Okay, I got a good view.
You want your bougie?
I'm gonna go without a bougie. Just yeah. Do we have a smaller chest? Actually, let's go. Okay. Come in. Can I get the balloon blown up? Balloon. So where's the right there? Great. Right here. Right here.
Size you put in?
It's a 7. There you go. Okay, go ahead. Do we get CO2 back?
You. YouTube down.
Can someone assess, listen?
Yeah.
We got ears.
We'll pause that there. So some of the systems that are critical, I think, in this, as I watch this are, multiple things, right? What you actually see are multiple teams interacting. So you have a surgical team and which is performing the procedure. There was an emergency physician that was, helping to provide cricoid pressure for intubation. There was an anesthesiologist that attempted to intubate initially. A lot of the systems that are important there were, having the right equipment. Did we have the surgical tools that were necessary to perform that procedure? Did we have the right sort of capnography that needed to detect this patient overall? Did we actually have everyone even assemble at the right time to perform this overall? And there was an organized sort of procedure, right? So we had someone that attempted to do direct laryngoscopy to perform the intubation. And when successful, there was an immediate intervention towards the next step. So the plan B was intervened quite quickly afterwards. So multiple systems that were important just to allow this procedure to perform successfully. And what emerged from a lot of this was that simulation really became a really helpful tool, I think, for a lot of people involved in QI and patient safety, because it was really one of the few tools that was able to proactively find latent safety threats that occurred before them actually causing harm in patients. So, i.e., we could discover things that in terms of our practice before something bad actually happened. It also allowed us to change some of our focus in terms of focusing on just sort of accidents and incidents to a larger perspective in terms of what we call safety 2 principles, which is, what are the everyday actions and outcomes and risks that actually result in good patient outcomes overall. So promoting those kind of positive effects and positive reinforcement overall. So I talked to you about sort of the concepts of systems integration before. I also introduced this concept of in situ simulation. And what sort of pulls these concepts together? I think one refers to sort of the location of simulation. One refers to sort of the scope of what we're looking at through some of our simulation work. But what kind of pulls these concepts together in terms of giving like a reason to these simulations is this concept of translational simulation. Translational simulation is a term that was coined by a mentor of mine that I look very up to. Her name is Dr. Victoria Brazel. She's an emergency physician that practices in the Gold Coast and Bond University in Australia. What she described in 2017 was this concept whereby simulation is done for the purposes of directly improving healthcare processes and outcomes. And what she described this was, and why this was necessary, was that in the sort of simulation world, there was a lot of fracturing and sort of false dichotomies about, what form of simulation is better, in situ versus center-based. And there's a lot of like loss in terms of, why we were actually doing simulation in the first place, the function of our simulation essentially, which was ultimately to improve patient outcomes overall. What Dr. Brazel sort of described in sort of her version 1.0 of this transitional simulation model was that simulation can be thought of and utilized for sort of 2 main reasons. One is for diagnostic purposes, and 2 is for actual intervention purposes. And in sort of the inspired as by Berwick's sort of PDSA cycles, there are interspersants of sort of healthcare performance that we measure to sort of see, how well things are going from a simulation. So ultimately, we conduct some simulations for diagnostic reasons. We measure sort of how the health system is actually doing it through these simulations. We can actually intervene using simulation to help improve some of the outcomes and narrow some of the findings that come about from this, re-measure healthcare performance, and then sort of repeat those cycles overall. So inspired very much by the PDSA cycles overall. And the principles behind translational simulation were sort of fivefold. One is that it incorporated the idea and concepts of systems integration, but also expanded on that in terms of including a lot of stakeholders that were important in those conversations as well. That it also frames simulation as not a sort of a single one and done event, but importantly as a strategy, an iterative process that happens sort of in a repeated fashion. Then it also included these concepts of being very problem focused. So what is the simulation really intending to perform and change and measure and improve, rather than just sort of doing simulation just because we can. And finally, again, tied to that is that sort of like functionally alignment. So we're doing the simulation to really measure a specific objective overall. And in this model, simulation really could be thought of in terms of three sort of main applications. One is that we use simulation to target improved performance with certain procedures and outcomes. Two is that we want to use simulation to test infrastructure changes and interventions. And three is to explore sort of workplace environments and the people involved in them. And importantly, one of the things that Dr. Brazel described earlier on is this concept of what workplace culture actually looks like. So I've talked sort of the concept of what translational simulation is, but I thought it'd be helpful at this point to actually talk a little bit about a couple of examples of what those actually entail. So I'm going to highlight, I think, three sort of core examples in terms of those three types of simulation utilities or applications I was describing earlier. And if we're talking about sort of targeted intervention to improve clinical performance, I think one of the ones that's important to discuss, first of all, is the work of Dr. Draycott overall. So Dr. Draycott is a obstetrics and gynecology specialist that practices in the UK. And this is an important article to discuss and let people know about because honestly, it's probably one of the first articles ever that was describing sort of patient-related outcomes and related to sort of education interventions. I think for our audience, one of the things I wanted to focus on as we talk about these studies is not necessarily the outcomes per se, but the methodology that goes behind determining this. So what this was that a single center retrospective cohort quasi-experimental studies. And really what they did was that they looked at a pre-training interval. So this was from 1998 to 1999. And they basically looked at the databases outcomes in terms of what 5-minute APGAR scores, which is a measure of how much resuscitation a newborn child requires after delivery, as well as neonatal hypoxic ischemic encephalopathy, or HIE. This was reported in sort of a standard UK-based maternity base. And what they did again was they had a pre-training session where they measured these outcomes. They performed a big educational intervention in the entire year of 2000, and then measured those outcomes afterwards. What they found overall was that if you compare the pre and post periods, substantial decreases when it comes to 5-minute APGAR scores, rates of HIE, as well as, and as a sub-analysis, rates of moderate or severe HIE, which are sort of clinical measures of how bad we're seeing encephalopathy signs. I think as our audience can sort of think in our heads right now, there are probably there are probably multiple limitations we can think of with this kind of design. Including the fact that there may be baseline differences between groups, which the study actually did comment on, that there were baseline differences between the groups. The difficulty to actually attribute certainly no causality data that can be attributed to this, but the ability to really separate out any other sort of changes that may have happened in terms of clinical performance during the time, aside from the educational intervention. But really, it was, as mentioned before, an important article because it's the first time an education intervention was shown to really change neonatal outcome overall. And honestly, it did spur a number of similar-based studies overall. I pulled this study in this figure from one of the earlier systematic reviews that I presented on because I think it's really neat looking at different outcomes of what people look at in these kind of designs. So roughly in a number of these outcomes, looking at performance of skills, people look at outcomes broadly in terms of those that happen within a patient, i.e. Conditions that arise from or with the patient, or secondly, patients that happen outcomes that happen to patients, which are conditions or events that happen to a patient. So if we're talking about within patient outcomes, with their sort of complications, and some studies look at rates of infection, pneumothoraces, rates that happen with chest tube insertions. People look at patient discomfort ratings. In particular with things such as colonoscopies. Important things like patient mortality or survival, particularly with the CPR-based studies. Durations of stays in hospital, subjective patient scales such as patient satisfaction, and not really any data in terms of sort of like more like laboratory data that have come about from there. Secondly, there's been some other outcomes that have been looked at that happen to patients, which include, how we define some sort of measure of, procedural success, how the evaluation is actually assessed. So if we're talking about, how a biopsy sample is actually collected, and ultimately like diagnostic accuracy overall. So secondly, in terms of another case example is, a simulation that have been used to test and plan infrastructure or interventions overall. And one of the big papers I think that's come about from this work, and one of the big players in this field is one of my colleagues, Dr. Andrew Petrosoniak and Chris Hicks over at St. Mike's. One of the things that they've been innovating a lot with is this idea of what we call design thinking informed simulation. And the problem that they were focused at addressing with this study that they described was the design of and build of a new emergency department. And what they used simulation for in this way is a model really to prototype their emergency department design. And they looked primarily at qualitative feedback regarding workflows, and ultimately looked at the latent safety threats that could be identified and some of the human factors optimizations that can be looked at. So they ultimately followed a 5-step process in which they looked at different sort of measures overall. So they started first of all with sort of understanding and empathizing sort of what people's input were, sort of a needs assessment. Then they looked at different designs and ideation. So they got together afterwards with sort of basic designs and options overall to pick from. And then the main utility of the simulation was in the different prototyping phases. Where they used simulation as a means for different sort of tabletop simulations. They actually had a crazy situation where they actually built multiple different prototypes of different room designs, ran the simulations in those different spaces, measured sort of different outcomes, and got feedback about which setup that they liked more. And then based on that, they ultimately built their sort of final sort of design, and then from there modified it further through some more in situ simulations before they actually put it into practice overall. So some of the issues they identified were things such as like phone connectivity, space to triage clinically sick patient, new roles they designed in terms of developing like patient transport areas, certainly a lot of stuff in terms of resuscitation room design, equipment carts that they utilize, physical space for critically sick patients, and also like important things such as like improving security presence, which was something that wasn't originally thought of overall. The third thing in terms of a case example to talk about is using simulation as a means to explore work environments and the people in them. And to be a little bit shameless here, I mean, this is some of the work that I was involved with in terms of the impacts work that I've been doing. Impacts was a project that I was fortunately to be involved in. What this was a prospective multi-center pre and post interventional study. And what we were looking at is really looking at ways that we can narrow some of the gaps in care that we were observing between specialized pediatric emergency department care, such as like at McMaster Children's Hospital, and general community emergency departments that we find. You know, one of the big things in my practice that I work around is the fact that 85 to 90% of kids that need critical care or emergency care will actually show up to a general emergency department rather than a pediatric emergency department that is actually more prepared to care for these kids. And what we looked at in these interventions was a change in sort of the weighted pediatric readiness score, which is actually a formally defined score that looks at, how well and prepared emergency departments are to care for kids with significant sickness. And it's an important outcome because it really is one that is correlated with child mortality. So places with lower pediatric readiness scores actually have a 4 times higher risk of child mortality with acute presentations compared to places with higher pediatric readiness scores. Also been correlated with other important outcomes such as like lengths of stay and adherence to guidelines, clinical guidelines that are out there. What we did is that we utilized simulation as a sort of initial assessment tool to see where gaps in care were. And then ultimately use the sort of a 6-month period to follow up and narrow performance gaps that we saw in our initial simulation, and then ultimately repeated assessments when it comes to our pediatric readiness. So at the beginning, we also did a readiness assessment, and at the end, we did a readiness assessment afterwards. We were lucky to be involved. We were involved with 33 other top pediatric academic centers across North America. And we all sort of had different outreach hospitals that we conducted simulation work in and measured our different outcomes in. This was a sample of the data that came about from our hospital when we performed simulation at our own site, and an example of some of the action items that came about from our own simulation internally. And what we found, I think, from this work is that in all of the metrics, that there wasn't a significant improvement in pediatric readiness if you pool all these different sites together. This one is the overall sort of pediatric readiness score and change pre and post. And these are the different subdomains of that pediatric readiness overall. And we can see significant improvements when it comes to administration, to the patient safety policies that are put into place, as well as a number of the procedures and equipment the processes and procedures that are there as well too. So I think at this point, I'd like to maybe flip. I talked a lot, I think, a little bit about again, the simulation concepts. What I'd hope to do is at this point, I think, actually involve you guys a little bit more. So I'm going to ask a very simulation-based reactions phase question. As the audience member here, can you describe to me what emoji you're feeling right now after what I've talked about so far? Feel free to enter it into the chat. Nice. Ella's pretty happy. Yes, Janet. Lots of thinking. Some thoughts. Love it. Oh, I love the spirally eyes. Yeah, perfect. Jocelyn. Perfect. Good going. Love these ones. Allison, I love the emoji. Abigail, I love the smiley face as well too. Oh, I love the monocle. Monocle's a very excellent one. Young Min, I like the sweat. Yeah, that's a good one. Mind blow, that's awesome. So the reason I bring up this idea, and I wanted to capture some of these as well too, is that Honestly, I think my emojis have changed a little bit over time. If you ask the younger me and whatnot, I think these concepts, like ultimately, were, the reason I'm involved in this, I really like this work, and I think it's important, and I think it's that it's honestly really cool. Now that I'm 10 years into this, my career and doing some of this work, I mean, I still find a lot of this really important. I think it's still absolutely critical. But I think as we've gone into this field, I feel a lot more of these other emojis as well too, that people are also sharing with me as well too. And I think the reason I bring up these ideas is that I think in doing some of this work, there are certainly issues that come about with systems integration and translational simulation that I think that that need to be addressed before we really honestly truly accomplish our mission overall. So, I mean, again, I still remain committed to the ideas that our education should improve patient outcome, but unless we address some of these issues, it can be challenging, I think, to really move forward overall. And I'm presenting this to this audience, I think, in merit, because I think honestly, this is one of the groups that can actually address a lot of these issues that come about. I think one of the first issues that I think that we need to address as we move forward in this field is essentially, this question of what is the pedagogy of systems learning? I think we've personified systems as a person, and I'm not really certain if that really is, accurate about what we're actually looking at overall. So, I mean, one of the reasons I like traditional simulation, and one of the reasons I'm so comfortable with it, is that it is rooted in education theory, right? It is a constructivist mode of learning where the simulation acts as an experience that we share, and from that experience that we share, we can grow and change and improve. And a lot of our debriefing science is based around that sort of Kolb's learning theory. I do wonder, as we talk about some of our systems learning ideas, is that we may need to consider additional pedagogies. I think about things such as connectivism, especially with IT, and how we're needing to have more than one group talk to each other, that is usually over time or distance or very rare occurrences. I think about the importance of thinking about how we think and have mental processes in high acuity, low occurrence events. I think of the importance of considering us as humans throughout all this process, and what our role as humans are in these sort of systems. And ultimately, I mean, I hope it's not behavioralism where we're going to sort of rats and the old Skinner models as well too. But I touch on that as well too, because I think one of the other second issues I think is that that I've started to appreciate is this sort of hidden curriculum, I think, of systems integration. I think what I mean by that is that I think even with the way that we frame some of these sort of systems integration models, where we put the user at the center, it in a ways, and I'm certainly guilty of this, is that I think we sometimes have thought about the importance of processes and in the environment sort of superseding users that are at the center of this. And to be honest, I think a lot of this changed because of COVID, and in my own work with reconciliation, just to understand that people actually are at the center of these successful systems, I think. And I think a lot of the work at this point has focused again more on the processes and environment. But I think we're hitting that point as a society, as a healthcare system, where now users are important to consider, right? So if we touch back on this example of, this critical procedure, at the end of the day, it is absolutely critical, what the user is doing, right? The fact that the surgeon has the skill to actually do the surgical procedure, the anesthesiologist has the situational awareness to say that I cannot intubate, we're needing to move on to the next stage. The technical sort of skills about, as soon as this patient is intubated, we're going to connect them through the confirmed tube location, etc., and move on with the rest of the resuscitation as well too. So at the end of the day, that's still a really important aspect that we need to look at. And I think even more importantly is the fact that I think that a lot of these models traditionally, or a lot of these systems thoughts, haven't really put patients or clients at the center of our healthcare processes. And I think nowadays, even if you look at the SEPS model, that's been revised to think in that the patient is now at the center, and we're thinking about these different healthcare systems that they journey across longitudinally, and it's the patient that goes through and journey throughout all this. So ultimately, I think that, my original question that I posed, why simulate and if it doesn't improve healthcare outcomes, I think over time that my thought has changed on that overall. My thought has changed to the point that I think that honestly, I believe and I really strongly believe this, that, all healthcare education can improve patient and client care. And really some of the questions that I'm more focused on now after being involved in this field is, how much does it affect patient care, and how do we show it overall? And to be clear, this is some of the work that it's not just myself that actually has been wondering these questions. Dr. Brazel herself, as well as Dr. Gabrielle Reedy, who's also a really interesting psychologist in the UK. They've looked at even revising what translational simulation is. So I'll put the link later on, but they've revised and looked at different ways to even structure what translational simulation is given feedback. So this is relatively hot off the press in 2024 as well too. So I've hit this point, I think, in our presentation where I think it's where I'd like to just sort of broaden the talk a little bit. So, and again, I'm really excited to talk to this part because I think with this audience here, there's a lot that we can chat about overall. So if we zoom out a little bit, I think, again, a lot of this talk is focused on simulation as an educational method. And I think traditionally, as simulationists, this is a question about translational and systems integration, because I think as a method, simulation generally stands as a method that is a lot more closer, I guess, to like actions that you perform in clinical practice. So we ask people to perform things in clinical practice rather than sort of, didactic textbook learning and knowledge overall. But one thing I think that's important to say is that, I don't believe that these concepts of systems integration and translational research are exclusive to healthcare simulations. I think there's actually a lot of applications that, if you think of these sort of educational methods, that really spread about to the other forms of education or that we're all involved with overall collectively as Merit. And I think within each of these different educational methods, there's a lot of considerations and strategies to which we should think about with systems integration and translational outcomes. So these include things as EDI and Indigenous health. How do we determine objectives of learning's curricular integration, what it fits into, synchronicity of different models of how we complete our education interventions, how do we target different audiences, and how do we actually promote things like mastery learning. I think my call to action, is to ask you guys overall, how do these concepts fit in your practice as an education scholar? And overall, on top of that, how does that fit in terms of Merit as an organization? And then ultimately, some of the enablers and barriers that are moving into this space. So maybe at this point, I can give a little bit of a pause and get some people's thoughts and opinions on these ideas, or any other questions I think that people have.
Okay, just reminding everyone, feel free to use the chat or just use the raise your hand function to ask your questions. Maybe I can start. It's not so much of a question, but James, I just wanted to understand. So the current state of, I guess, translational simulation or the more systems-based understanding has been more focusing on the processes and the systems, although the individuals and the teams are a part of that bigger system, but that we almost lost track of the importance of the individual within that system. Did I understand you correctly?
I think so. Absolutely. I think that's part of the process. I think we see it now, like even in our practices, like it's a very it's not uncommon to feel that you're part of a big system in a cog, even though really those systems should be designed to help us out at the end of the day. So I think that's been a big re-emphasis and a big change in terms of just in general, like a lot of our healthcare atmosphere has changed from in the most recent years, I would say. I think Victoria Brazel has also mentioned it in some of her revisions. This was something that she had pointed out as well too, that there's been this sort of false dichotomy also between systems being like translational research being superior to traditional education research. They're not one is superior to the other. They're just different forms that accomplish different objectives.
Okay, thank you. Anyone else have a question?
That's okay if people don't. I think the reason I pose this ultimately is I think these are deep questions for us all to ponder. I think that there's a lot of applications in our work, and especially our work for it to be relevant to the patients or clients that we ultimately serve. And I think there's challenges and enablers that are difficult in terms of moving these spaces just to consider as well. Oops, I have different timers here overall. So, as I think about this, some of the challenges I think that we should be aware of as we move into this space is the fact that I think, again, there's some opportunities here. So one, I think that as education scholars, I think there's opportunities for us to get involved in terms of really helping figure out, what pedagogy we're talking about overall. Daniel has a question.
Yeah, thanks. Sorry, I'm driving, so I might be a bit noisy, but thanks for that great talk, James. I guess just thinking about your question there and, interested in hearing your thoughts about it. One of the things that I found oftentimes is a big challenge to engaging in this type of systems or translational type of research is the data collection or data available. And so, oftentimes the system that we're working in or existing in and that we want to study and improve, they're not resourced to collect the data that we need. And that might be in terms of, knowing that we're actually making a change that matters, or understanding the problem in terms of like a cause analysis or root cause analysis. So I find that oftentimes we end up doing, currently I'm doing a education simulation that's involving multiple healthcare professionals at St. Joe's, focused on how they receive requests or questions about MAID, assisted death, given a lot of institutional and cultural challenges in that area of healthcare in that institution. And it's, we've designed the education, but we're missing, we've designed the simulation, we've implemented it, but what we're missing really is a sustainable, effective way of collecting data to be able to know exactly the impact that our session is having and whether or not we're leading to change. So I'm curious if you have any thoughts or experience on addressing that challenge of data points and limited data availability.
Oh no, Daniel, I 100% like I live this pain. I feel like I've like hearing this question. I think so many things. I mean, like when we're trying to show these sort of correlations, I think one of the issues that comes up is the duration, the scope creep of this increases so much. Like for us to intervene and then to actually see improvements and changes, just the amount of resources that are required for that. I mean, us as education researchers often aren't funded for that. We don't necessarily have the connections per se in terms of direct patient contacts. That some of our clinical our clinical researchers may actually have as well too. So it's challenging to that. And I think the longer you put this scope out, it sort of dilutes the, what was the effect of this intervention in terms of actual patient outcomes just overall. I think the key thing I think that's been in my practice or what I've seen from others is that this idea of, I think, collaboration with larger groups becomes more important. I think having like we in some of our work, we've actually had some of our hospital administrators get involved. I think they've been really helpful in terms of getting people to actually monitor things. And building it in terms of the systems and the systems that are in place have been really effective. So for us, the most important thing I think in a lot of our work is actually connecting it with our nursing educators system, because the nurse education system is so robust. They have like nurse educator specialists that connect across different departments overall. And they have like essentially dedicated time that are focused in terms of this. So having someone to help initiate that on the ground level has been important. Where impacts, so what I presented was impacts sort of version 2.0. Impacts 3.0 has really focused, and one of the things that we found in that sort of work is the importance of embedding champions and supporting those champions as well, and doing those local sort of works as well too. But I would say that a lot of these challenges that you've highlighted, Daniel, are so big. I think you know, a lot of our funding models aren't necessarily built in that way. And I think what it means for us is that I think connecting earlier with people from the clinical research perspective, involving additional skill sets as well too, is an important thing as well too, to get involved. So and that's one of the challenges, honestly, with this work, I think, is that what it does is that by introducing these concepts, it honestly just the scope of what we need to do really increases, right? So I think we have this expertise in education and research around those expertise around that. But sort of the extra skills of knowledge translation, of patient follow-up, and those sort of things has become a bigger thing. But I think it's that whole package. I think we also bring something to the table that others don't necessarily bring. So I think we have a lot to bring to the table in these conversations. And I think a lot of research happens that just stalls because we aren't involved in it, because we actually have a lot to, I think, to offer to that.
And James, I was also wondering, yeah, you didn't use the word sort of latent safety threats exactly, but obviously I think you alluded to it at different points. But I was just wondering, where do you see work that's around latent safety threats? And it might be worth to just explain to everyone sort of what that is, but where do you see that within the different purposes of using simulation for translational purposes, or within the within the impact model or the SIPS model?
Yeah. So if I can introduce the term a bit more, sorry if I didn't explain that. A latent safety threat is basically where you have basically a healthcare system or setup where basically this is an error that's waiting to happen, that it just hasn't happened yet because we haven't encountered that situation. So a classic example would be where we have two fluids, one contains potassium, and if you give it, you can cause cardiac arrest. That's right next to the normal saline fluid that doesn't contain potassium and it's not appropriately labeled. And if you do a simulation where that actually happened, but it happened to a mannequin as opposed to a human being, we would call that a latent safety threat, and it's a big safety win because no one actually got hurt. We need to redesign. We certainly need to move that fluid away from that, or label them a bit better. But it didn't happen to the patient, so this is actually a big win, I think, from a safety perspective. So I think that's still been a big seller these days, I think, of doing simulation work. I think a lot of I think certainly amongst the HHS group, I think that's one of the big pros, I think, that supports our work. And I know that our group is integrated, and the Children's Hospital is integrated with it's actually overseen by the patient and quality group as opposed to education. That's where the simulation program fits overall.
And it's another way to almost like, it's not directly related to patient outcomes, but it kind of is. And it's another sort of seller point almost for why this work is important.
I think that's been a big thing in my work, is actually selling people on the importance of simulation and getting actually a system to build up to measure these latent safety threats. So even getting a system to put the latent safety threats as reportable items so that you can actually follow up on has been something that I think we've had some conversations on. I know that in a lot of community hospitals, in fact, that it sits as part of their Code Blue committees in terms of these simulations, and they're actually interventions to correct them. I actually just thought of one other thing as well. I think that was important to highlight, and I think Renata, for actually bringing it up, is I think one of the methodologies I think that we should lean on a bit more in terms of understanding impact is qualitative methodology as well. There are a lot of issues, I think, with us not performing qualitative research in the right ways. I think with the rigor that qualitative research requires. But I think that as we look in terms of these issues of truly understanding how our education interventions impact people, I think qualitative is one of those fields where we can really understand a lot more of. So I think that's a field I think that as education scholars that is really an area that's an area of potential growth and contribution of it, because yeah, I think we need to do qualitative research the right way, but it's actually one of those ways because it's such a complex phenomenon of what we're doing. Actually, the answer or the way to understand this phenomenon a bit more is actually to conduct more effective qualitative research from this. So yeah, and I definitely would love some of those extra connections as well too.
Great. Thank you so much, James. And sorry, finish and then because I know it's 6:02, so please.
Yeah. So ultimately, I just wanted to say two last things. Ultimately, is that we aren't alone at McMaster, I think, from this. So one of the practical things I would suggest that we look up and also be involved with, I think a number of us may be involved with this as well, as the Center for Evidence-Based Implementation. So it's a Hamilton Health Sciences program, but McMaster is also involved. This website lists a number of training and toolkits and consults that they offer as well too. So interesting group that we can get connected with. They have a lot of knowledge translation experts, so people may be interested if they're interested in getting involved in this field as well too. And they have some people that fill other sort of knowledge and gaps and additional skill sets as well too. So yeah, I think in lieu of time, I'm just going to sort of state again the main points here is that, I think that traditional healthcare simulation, that the way it's traditionally defined is that it focuses on individual and team-based outcomes, and where systems integration adds to this picture is that thinks about some of the pictures, the scope beyond that. So what are the external factors that affect these individuals and teams? However, I think there's an increasing need to honor the individuals and patients that are at the center of this as time has passed. I think translational simulation is important to think of as a subtype of simulation. It's certainly not better than any other type of simulation, but to know that really as a concept, it focuses on patient and client outcomes overall. I do believe strongly again that healthcare is education is a way that we improve patient or client care. And to me, I think the question is, how much, and really some of the fun stuff for us as scholars is, how do we show it, or how do we show what works or doesn't work? And finally, I think that ultimately it's important that we balance individual and team-based and system-based education research, because I think we need the whole picture, just ultimately to understand everything. So lots of thank yous. But I'll reserve that after the limits of time.
Thank you so much, Jim. Really appreciate your presentation. I think we all learned a lot, and thank you to those who joined our merit rounds today. And again, we'll see you in a month, and you'll see the advertisements as we get closer to our next round. So thank you again, everyone, for attending, and thank you again, James, for being a great speaker.
Oh, thank you everyone for attending. Just appreciate again the privilege.
Thank you so much.